Clinically relevant amoeba, flagellates, and ciliates. Protozoa. So the protozoan parasites include pathogens and non-pathogens, known as commensals, that closely resemble pathogens. To ensure appropriate therapy when necessary and patients not being treated unnecessarily, it's important for the laboratory scientists to recognize and differentiate the pathogens from the commensals. Commensal parasites must be reported in the test results. The presence indicates contaminated food or water, and specimens should be closely examined for pathogens. Intestinal amoebae. Intestinal amoebae, considered the most difficult to identify because they're small size. There's two morphological forms, trophozoites and cysts. Species identification is often based on size, the number of nuclei, the nuclear structure, and the presence of specific internal structures. In a direct wet preparation, the motility of the trophozoite may aid in the presumptive identification. Overall, the permanently stained smear is the best preparation to identify amoebae. Entamoeba histolytica is recognized as a true pathogen. Questionable status is blastocystis, which we'll talk about later on, and other amoeba are considered non-pathogens. All of the amoebic organisms discussed here live in the large intestine and have two morphological forms, the trophozoite and the cyst. The trophozoite is the motile and feeding stage that reproduces by binary fission, the same way that bacteria reproduce. A cyst is an infective, environmentally resistant stage. The multiplication of nuclei serves as a reproductive function. Blastocystis hominis has more morphological forms than what's listed here. Life cycle. Life cycle of the amoeba is relatively simple, with direct fecal-oral transmission in food or water. There's no intermediate hosts. Humans ingest the infective cysts, which insist in the intestinal tract, and the emerged trophozoites multiply by binary fission. Trophozoites colonize the cecal area, and then as the stool is formed, it dehydrates it, forming more cysts, which are then passed out of the body. So this is the generalized life cycle. So the human consumes the cysts. The cysts go into, trying to follow along here. This diagram's going arrows in all different ways. So the existing of the organism happens in the large intestine, and then the trophozoite is released. So the trophozoite can be passed out through the stool. If it is passed out through the stool, it typically just dies. It's not going to be infective in the trophozoite form. Otherwise, the trophozoite can reinsist, and then those cysts can be passed through the stool and transmitted to the next person. Sometimes these trophozoites can burrow through the intestinal wall and become extra intestinal infections, and they can eventually travel to the liver and cause hepatic abscess. Treatment is administered only for Entamoeba histolytica infections. Invasive amoebiases are treated with systemic drugs such as metronidazole and luminal amoebicides. Treatment for non-pathogens is not indicated. Also, if you're in an endemic region, sometimes they won't treat. Luminal amoebicides are given to carriers in non-endemic areas to prevent the invasive phase and reduce the risk of transmission. So Entamoeba histolytica and Entamoeba dispar are morphologically identical. Histolytica is a pathogen, dispar is non-pathogenic. So this is where they look identical, but we have to be able to differentiate them somehow because histolytica will cause significant infection while dispar really does nothing to the body. They're found worldwide, especially in the tropics and subtropics, but more common in developing countries. Ranked third behind malaria and schistosomiasis as a cause of death resulting from parasitic infection. Parasite presents in several ways: asymptomatic colonization, amoebic dysentery or colitis, and extraintestinal amoebiasis. Asymptomatic colonization, no symptoms, but it colonizes the large intestine. Amoebic dysentery is when the trophozoites are able to burrow through the intestinal wall, and that causes colitis or inflammation of the intestinal wall. Extraintestinal amoebiasis is when it actually leaves the intestine and starts to do damage to other abdominal organs. Symptoms in acute infections: abdominal tenderness and cramping, fever, up to 20 diuretic stools per day that contain trophozoites, blood, and mucus. Some stools contain Charcot-Leyden crystals, which is the breakdown remnants of eosinophils. Their presence in the stool is suggestive of an intestinal parasitic infection, but is not specific for E. histolytica. In severe E. histolytica infection, the patient may shed pieces of intestinal mucosa. Some patients develop an amoeboma, amoebic granuloma, or a tumor-like lesion that forms on the submucosa of the intestine, an area of chronic lysis and infiltration with neutrophils, lymphocytes, and eosinophils. In chronic infections, there may be alternating asymptomatic periods and diarrheal episodes. So this is the comparison of intestinal amoeba. So here's the organism here. So Entamoeba histolytica, Entamoeba coli, Entamoeba hartmannii, Endolimax nana, and Iotamoeba bushlii. And then this is the cyst form. Now, one thing to note is when you're doing diagnostics, there's some key features to pay attention to diagnose these various pathogens. So with Entamoeba histolytica, the cyst is usually more diagnostic, and you can see 4 nuclei with this elongated body here. Entamoeba coli is a non-pathogen. So this is E. coli, but obviously not the bacterial Escherichia coli. This is the parasite E. coli. And E. coli is differentiated by usually 8 nuclei, and then this elongated body, the chromatoidal bars. The difference between Entamoeba hartmannii and E. histolytica is going to be you're not going to see a very obvious glycogen vacuole inside of here. Endolimax nana, a little bit smaller. Iotamoeba bushlii has this very obvious nuclear pattern up at the top of it. So as we go through these, you'll be able to look at them, and you want to study the key features that's going to help you differentiate these. Now, Entamoeba histolytica is our only pathogen here. The other ones can be found in and have been associated with diarrheal infections, but that's just because they happen to be in the area of dirty water or dirty food. So typically they aren't the only organism that's going to cause a problem. They just happen to be around while another organism is causing a problem. Trophozoites in the stool that may be seen in a direct wet mount or trichrome stain smeared in patients with diarrhea. If there are no ingested red blood cells, the organism must be reported as E. histolytica E. dispar. Immunoassays are necessary to differentiate these species. So here's E. histolytica trophozoites. Cysts of E. histolytica may have 1 to 4 nuclei, each with a small central karyosome and fine, evenly distributed peripheral chromatin. The cytoplasm may occasionally contain chromatoidal bars composed of ribonucleic acid. The chromatoidal bars are cigar-shaped with rounded ends. In young cysts, there are often multiple bars. In mature cysts, they may only show 1. Average size is listed. Discrete glycogen in young cysts stain light brown and iodine wet mount. In the more mature cysts, the glycogen is diffuse. Cysts can persist for 2 to 4 weeks in a moist environment, but may be killed by drying temperatures over 55 C, superchlorination, or addition of iodine to drinking water. Here's a picture of the cyst, and then more pictures will be provided as we go through here. Some antigen testing kits detect E. histolytica antigens without excluding E. dispar. Others differentiate the two. Point-of-care tests using immunochromatographic techniques assist with the rapid diagnosis of E. histolytica infection. Antigen detection assays can be used on other specimens besides feces. Multiplex molecular assays for GI syndromic tests are available. E. histolytica is often included. So here you can see that chromatoid body. Here you can see another one. Kind of looks like a crazy smiley face. Here's another one. Kind of looks like 2 eyes and a weird mouth. And here's some additional pictures. and the trophozoite. Entamoeba hartmanni. Once known as small race E. histolytica, it's a non-pathogen. It generally resembles E. histolytica, but it's more likely to have an eccentric karyosome or uneven peripheral chromatin resembling that of Entamoeba coli. So this is a picture of that, and some additional pictures. Entamoeba coli, commonly found in intestinal commensal, transmitted by ingestion of cysts in fecally contaminated food or water. Mature cyst has 8 nuclei. Immature cyst may have 1 or 2 large nuclei. So this is a picture of the trophozoites. And then the cysts. So on the qualifying exam, if you see a picture that looks like it has 8 different nuclei inside of it, E. coli and Entamoeba coli is your best bet as selecting the correct answer. And here are some more pictures of that. Endolimax nana, trophozoite stage 5 to 12 micrometer. In a wet mount, motility is sluggish. In a wet mount, it may be difficult to distinguish the large karyosome of E. nana from the karyosome of E. hartmanni. Cyst is oval-shaped or spherical, has up to 4 large nuclei. Characteristic nuclei resemble buttonholes. So that's a picture of E. nana. Some more pictures of the cysts. And additional pictures are provided. So for the test, these are exactly where the pictures would come from if you have to identify these ones. Iotamoeba bushleyi is less commonly encountered compared with other non-pathogenic amoeba. The nucleus is composed of a single irregularly shaped karyosome surrounded by achromatic granules and a thin nuclear membrane with no peripheral chromatin. So that's a picture of the trophozoite and the cyst. Here's another picture. You can see the nuclei and then this large glycogen vacuole. And then this is a really great picture where I could take some pictures from for the test questions. But here it shows the difference in size and shape of the cysts and the trophozoites for all of the main species that we talked about. We didn't talk about this guy, and that's okay. You won't have to know that one. And here are cartoon drawings of them. Blastocystis. So taxonomy is unresolved, originally considered as a yeast. Recently, it underwent taxonomic reclassification. Genetically, it closely resembles Protozoan lacerate, a flagellate. However, blastocystis is non-motile and doesn't have a flagella. Our RNA analysis indicates that it's related to brown algae and water molds. Blastocystis is one of the most common intestinal protozoa and has a prevalence of greater than 50% in developing countries. Infection occurs in immunocompetent and immunocompromised individuals. Blastocystis has come to prominence as a possible cause of diarrhea in humans, although there's a lot of controversy and conflicting results from numerous studies. That's a picture of it. You can see the little arrows pointing to it. And moving on to tissue amoeba. So tissue amoeba, free-living, thermotolerant, wide range of temperature, pH, salinity, found in soil and water, freshwater sources, domestic water supply, sewage, swimming pools. They feed on bacteria in the environment. Mode of transmission to humans would be inhalation of the nasal mucosa, travel along the olfactory nerve to the brain, hematogenous spread from the lungs or skin, lesions. Although the number of infections caused by these organisms is low, they're very difficult to diagnose and treat and are associated with a high mortality rate. Naegleria fowleri and Acanthamoeba species have been recognized for many years as amoeba, most commonly associated with CNS invasion in humans. And there's a couple others that are also implicated in rare cases of encephalitis and meningitis. Comparing Naegleria fowleri and Acanthamoeba to each other, this table does a good job. Naegleria fowleri is the causative agent of primary amoebic meningoencephalitis, or PAM. The press sometimes refer to N. fowleri as the brain-eating amoeba. It's a rapidly fatal condition involving the central nervous system. A common factor in infection is the report of recent swimming or other water-related activities in warm artificial lakes or brackish or muddy water, or exposure to the bottom sediment. Water skiing, wakeboarding, or other activities that increase the chances of forceful entry of water into the nose may facilitate infection. Tubing down the river. When I lived in Texas, way back when, there was the river that everyone would always go tubing down, and it was right just north of San Antonio. They would go, the name of the river is escaping me. Anyways, a girl, 13 years old, tubing down the river and ended up getting some water splashed up her nose, and the amoeba got into her brain and it killed her. And it was all over the news when I was down there to be careful of water sports and wear like nose plugs when you're going into the water because these are present. There was another big outbreak that happened in Tennessee at an outdoor water park. So this outdoor water park was just a natural body of water with some tubes and some things that people could jump around on and play around on. Well, there was a large number of cases that came from that area of people that ended up getting this. With this, it is extremely fatal, and up until recently, they were not able to save anyone. Now they've had some limited success in saving people when they get infected because this does mimic so many other potential infections that by the time they figure out what it is, it's usually too late and treatment doesn't help. The damage that's done to the brain is permanent and not reversible, so it's really important to catch this quick and figure out what it is quickly. Unfortunately, not a lot of people know about it, so they go splash around in natural bodies of water that don't get too cold and end up getting this in their brain. Life cycle is relatively simple, so there's the free-living amoebic trophozoite, the transient flagellate form that appears when there's scarcity of nutrients, and the environmentally resistant cyst. Trophozoite enters the nasal cavity through inhalation of contaminated water or soil. The amoebic form colonizes the nasal cavity and invades the nasal mucosa, attaches to olfactory nerves, penetrates the cribriform plate, moves along the olfactory nerve to the olfactory bulb, and moves into the arachnoid space, then spreads through the CNS. Thought to be related to inhalation of a large number of organisms or forceful entry of water into the nose, microtrauma, and to the virulence of the strain. Cannot be distinguished from bacterial meningitis. Incubation period usually 2 to 3 days, but may range up to 2 weeks. Initial symptoms: severe bifrontal headache, fever, stiff neck, and nausea and vomiting. CSF will show evidence of increased intracranial pressure, increased levels of neutrophils and protein, and decreased glucose levels. In the late stages, there may be increased numbers of red blood cells in the CSF. Organism multiplies in brain tissue, and within 2 to 4 days, the patient can experience drowsiness, confusion, seizures that progress to coma, and eventually death. Disease is usually fatal within 1 week of clinical symptoms. At autopsy, there will be evidence of trophozoites along with purulent exudate, edema, and hemorrhagic and necrotic areas of infection in the brain. N. fowleri is capable of direct cell-to-cell damage, resulting in destruction of red blood cells and other cells, including nerve cells. Because of the symptoms resemble those of bacterial meningitis, specific treatment may be delayed, yet the possibility of cure depends on early diagnosis. Aggressive therapy consists of intravenous and intrathecal administration of amphotericin B, rifampin, miconazole, fluconazole, and azithromycin have been used in addition to amphotericin B. Other treatment measures: survival in several cases has been linked to the additional procedures, including use of medically induced hypothermia and the experimental drug miltefosine. Laboratory diagnosis: finding motile amoebic trophozoites in CSF. And there's a picture of N. fowleri. Acanthamoeba have been linked to several clinical conditions, including GAE, cutaneous infections, and amoebic keratitis. Legionella, Vibrio cholerae, and E. coli 0157. The role of these bacteria may play, if any, in pathogenicity is unknown. Cutaneous acanthamoebiasis, associated with patients with AIDS whose CD4 count is less than 250 per microliter. Symptoms: chronic non-healing lesions that may present as nodules, papules, or ulcerations, especially in the extremities and in the face. Lesions may develop at the site of inoculation or may occur as a result of hematogenous dissemination from the lungs. Trophozoites and cysts can be seen in biopsy preparations of the lesion. Granulomatous amoebic encephalitis. Subacute incubation time is unknown, may range from months to years. Symptoms: drowsiness, loss of reflex activity, hemiparesis, headache, stiff neck, personality disorders. The trophozoite is uncommonly seen in CSF, and diagnosis is typically made by brain biopsy demonstrating cysts or trophozoites or both. Histological preparations of the brain at autopsy show inflammatory lesions containing many segmented neutrophils, eosinophils, and trophozoites. A specific therapeutic regimen has not been established because most infections have been diagnosed at autopsy. Disseminated acanthamoeba infections have been treated with amphotericin B, pentamidine, isethanoate, fluconazole, ketoconazole, and cotrimoxazole, trimethoprim, sulfamethoxazole. Amoebic keratitis has been identified in immunocompetent individuals since the 1980s. Group at risk: individuals who wear contact lenses, especially the soft and extended wear types. This group comprises greater than 80% of identified cases. Factors in these infections: improper storage and disinfection procedures. A history of corneal trauma, swimming with contacts in, may cause corneal trauma and subsequent colonization. The organism binds directly to the corneal epithelium via acanthopodia and produces proteases and other enzymes that cause cell lysis. Patients experience photophobia, blurred vision, inflammation, ring infiltrates, and pain in the eye. Phase contrast microscopy of direct wet mount preparations of corneal scrapings can reveal the trophozoite or cysts. The use of calcofluor white increases detection of the organisms. Permanent stain smears such as trichrome and right Jamsa stain may also demonstrate the trophozoite in clinical specimens. And there's a picture and a few more pictures. The cyst morphology is listed. Treatment: cutaneous infections use topical applications of different types of drugs. Despite treatment, patients with systemic infections have a poor diagnosis, and patients with keratosis lose their sight in the affected eye. And that should be S-I-G-H-T, not S-I-T-E. Balamuthia mandrillaris, an emerging opportunistic pathogen that has been identified as a cause of skin lesions and GAE, primarily found in soil. Since 1990, when it was first linked to human illness, to 2019, this free-living amoeba has caused more than 200 cases worldwide and about 100 cases in the United States. The mortality rate is greater than 95%. It's unknown if there's a genetic predisposition or if the type of work in which causes the individuals engage increased exposure risk. Can occur in immunocompromised and immunocompromised hosts. Humans become infected by inhaling airborne cysts of the organism or by direct inoculation through skin lesions. There have been several reported cases of transmission via organ transplants. No person-to-person spread has been documented. Skin infections present as relatively painless nodule. Once the organism enters the body via the lungs or skin, it spreads hematogeneously, ultimately reaches the blood-brain barrier. In the CNS, the organism multiplies by binary fission and causes a necrotizing hemorrhagic infection similar to that caused by acanthamoeba. Symptoms: onset is insidious, fever, headache, stiff neck, vomiting, and photophobia. Progresses to personality changes and seizures. Onset of symptoms can occur weeks to months after infection. When the brain is infected, the time to death is short. Treatment involves a multiple antimicrobial regimen. In most cases, infection is identified at autopsy by finding trophozoites and cysts in the tissue. Ciliates. There's one ciliate, so this one should be sweet and short. Neoballantidium coli. Used to be called Ballantidium coli, now it's Neoballantidium coli. It's the only ciliate that's pathogenic for humans. The largest protozoan. Natural host is pigs, accidental host humans. Lives in the large intestine, may cause mucosal lesions. No extraintestinal infections have been noted. Most infected individuals are asymptomatic. Organism can cause self-limiting diarrhea with nausea, vomiting, and abdominal tenderness. Life cycle is similar to that of the amoeba. Infective stage is the cyst. Trophozoite is covered with short cilia, and it's oval-shaped, and it's pretty large. This is a picture of the trophozoite and the cyst. And here are some more pictures of the trophozoite, so you can see all of the cilia really well on this picture. And here's the cyst. And the cyst is distinctive because it has this large vacuole here. Pathogenic intestinal and urogenital flagellates. So the generalized life cycle for intestinal flagellates, humans are going to eat the infected cyst in contaminated food or water, and then the cyst hatches basically into a trophozoite. It goes through its asexual reproduction, and if it's lost as a trophozoite, it's typically not infective. If it is formed into a cyst in stool, that's the infective stage that can go on to infect the next person. Giardia duodenalis, formerly known as Giardia lamblia and Giardia intestinalis, is the causative agent of outbreaks of gastroenteritis and traveler's diarrhea. This is one of the most commonly reported intestinal protozoans in the United States. The main groups at risk: travelers returning from endemic areas, hikers who drink untreated water from streams, and children in daycare centers. Outbreaks have been reported from swimming pools contaminated with feces. Cysts may remain viable for several months in cold water, somewhat resistant to chlorine and iodine, susceptible to desiccation and heating to 50 degrees Celsius. Reservoirs: animals such as beavers, the source of infection for backpackers who drink from water or streams. Condition is known as beaver fever, backpackers' diarrhea. Along with E. histolytica, G. duodenalis has been identified as a sexually transmitted pathogen among those who practice oral anal sex. Clinical infection: a low number of cysts, as few as 10, can initiate infection. After cyst ingestion, gastric acid in stomach triggers the beginning of the excistation. Clinical presentation ranges from asymptomatic to acute infection or chronic infection. In most patients, self-limiting diarrhea with malaise, cramps, nausea, and abdominal tenderness after an incubation period of 12 to 14 days. Explosive, foul-smelling, non-bloody diarrhea is present. No fever or evidence of inflammation. Symptoms last 1 to 4 weeks, and the patient may lose a significant amount of weight. Children 6 months to 5 years of age are most susceptible to metabolic problems. Treatment: metronidazole, albendazole can also be used. Laboratory diagnosis: feces serves as a usual diagnostic specimen, but shedding of the cyst is irregular, and multiple stool specimens are often required for diagnosis. EIAs using monoclonal antibodies to detect soluble antigens are available. There's new lateral flow immunochromatographic tests that are available. DFAs, direct fluorescent antibody tests, can also be used to identify the cysts of Giardia in the specimen. Several of these DFAs also contain a monoclonal antibody that identifies Cryptosporidium. There's also new molecular tests that are available. They're multiplexed PCR tests that can detect many different types of common intestinal, not only parasites, but other types of pathogens like bacteria that can cause infection in humans. So this is a picture of the trophozoites. So here it kind of looks like two eyes, and then it has its little flagella. Here's the cysts, and then here you can see these. That's what it looks like there. And here's some more pictures. I like to think of these guys as like little smiley faces, because if you like pay attention to this one, you can see the two nuclei, and then it kind of comes down and makes almost like a smiley face type structure, kind of saying like, haha, I'm going to give you diarrhea now. It's kind of like little ghost-like structures inside. Really interesting shape to me. Dientamoeba fragilis. So D. fragilis has a worldwide distribution with prevalence ranging from less than 1% to greater than 40%. For many years, there were questions about the pathogenicity. The organism was isolated from stools of patients who were asymptomatic and from those who had GI symptoms such as abdominal pain or tenderness and diarrhea. Evidence now suggests that the organism has a role as a pathogen in either acute or chronic infections. As with blastocystis infections, links to IBS or irritable bowel disease have been suggested. Case reports show that treatment with metronidazole results in the clearance of the organism and alleviation of symptoms. Some but not all molecular studies have shown evidence of that D. fragilis DNA is inside the pinworm egg. Whether the cyst-like structure can be confirmed as a transmission stage remains to be determined. Electron microscopy studies of ultrastructure, small subunit rRNA analysis, and the lack of a cyst stage all indicate this is closely related to trichomonads. D. fragilis has apparently permanently lost its flagella. And there's a picture of it. Since trophozoites do not usually survive the concentration technique, they will only be detected on a permanent stain smear. D. fragilis can be difficult to see on a trichrome stain smear because its outline is often indistinct and blends into the background. No commercial tests are available, and microscopy remains the method of choice. So this is a picture of it. And a few more pictures available. Trichomonas vaginalis. So T. vaginalis is a pathogen of the urogenital tract in men and women causes trichomoniasis, one of the most common non-viral sexually transmitted diseases, with an estimate of 180 million cases worldwide. Humans are the only host, and the presence of infection with the organism is associated with other STDs, especially gonorrhea. Trichomoniasis have been increasingly associated with adverse pregnancy outcomes, including transmission of the organism to the newborn, cervical neoplasia, and pelvic inflammatory disease. T. vaginalis lacks a cyst stage. The trophozoite stage is infective through sexual contact. In women, the infection is primarily localized to the vagina, resulting in itching and production of a frothy, creamy, mucopurulent vaginal discharge, as well as dysuria. About 1/3 of infected women, however, are asymptomatic. A chronic state can develop with mild symptoms of pruritus and scanty discharge. Women with chronic infection are often a major source of transmission to sexual partners. Men infected with T. vaginalis are usually asymptomatic and serve as carriers, although they can develop nonspecific urethritis with a milky discharge that lasts up to 4 weeks. T. vaginalis is now considered an important cause of non-gonococcal urethritis. In women, it's typically diagnosed by finding the trophozoite in vaginal discharge or occasionally in urine. In men, the trophozoite is seen in urine or prostatic secretions. Culture specimens should be held for up to 5 days and then examined microscopically through the pouch. So in order to identify these guys, we would inoculate a specimen into pouch media, and the pouch is put directly under the microscope. PCR methods and antigen detection assays are also commercially available. Rapid antigen detection tests are based on immunochromatographic EIA procedures using monoclonal antibodies. Treatment: metronidazole. Treatment of sexual partners is suggested to obtain optimal cure and prevent reinfection. And this is a picture of these guys. So these are a lot more round. You can see the flagella very clearly. And there's some more pictures. So non-pathogenic intestinal flagellates, chylomastic mesnili, trophozoite morphology, pear-shaped, prominent cystome, prominent nucleus, cyst morphology, lemon-shaped, an anterior nipple, nucleus, cytosome, and curved fibrils are visible in a stained smear. So that's a picture of chylomastic mesnili. And here you can see this is kind of a very typical picture of the organism. And you can review the additional pictures and then pause the video and take a look at these comparisons. Blood and tissue flagellates. The hemoflagellates in the genera Leishmania and Trypanosoma differ in several ways from the intestinal flagellates. First, they're transmitted by insects. Second, they can have different life cycle stages. The trypomastogote and amastogote are the diagnostic stages found in humans. So there's amastogote, promastogote, epimastogote, and trypomastogote. So in the human, we can find the amastogote and trypomastogote. In the insect, we can find the promastogote and epimastogote. Amastigote is an obligate intracellular parasite found within the macrophages in liver, spleen, or bone marrow cells caused by leishmaniasis, or in diseases caused by leishmania. May also be seen in cardiac or GI cells of patients infected with Trypanosoma cruzi. The trypomastigote is a flagellated form found in the blood, lymphatic fluid, or CSF patients infected by Trypanosoma species. The epimastigote and promastigote are stages seen in the insect vectors. For leishmania, it contains several complexes of at least 20 different species that can cause disease in humans. Leishmania tropica, mexicana, brasiliensis, and donovani complexes. Leishmaniasis is a zoonotic infection in which dogs and rodents are the primary reservoir hosts for all species. Humans serve as an accidental host. The vector sandflies of the genre are listed. L. tropica causes cutaneous leishmaniasis or oriental sore. It's Orient and in North and Central Africa. Disease progression, a crusted circular lesion. The lesion begins as a small red papule at the site of the insect bite. It resolves in several months and provides incomplete immunity against future infection. The Mexicana complex, New World cutaneous leishmaniasis, South and Central America. Another form of the disease, Chickler ulcer, also associated with this complex. Lesions on the ear, they're self-limiting, do not invade mucosal surfaces, but secondary bacterial infections can occur. Brasiliensis, mucocutaneous leishmaniasis, also known as espundia, found in Mexico and Central and South America. Initial lesion that increases in size and targets oral and nasal mucosa. Gross disfigurement of the soft tissues with extensive tissue destruction. Donovani causes visceral leishmaniasis, also known as Kala Azar, endemic to parts of South America, Africa, Southern Europe, and Asia. The organism spreads via the lymphatics and invades the liver, spleen, lymph nodes, and bone marrow. Symptoms present with headache, malaise, fever, anorexia, and weight loss. Fatal within 2 years if not treated. Other possible symptoms, splenomegaly and hepatomegaly. So spleno is talking about enlargement of the spleen. Hepato is talking about enlargement of the liver. With elevated liver enzyme levels. Hypogammaglobulinemia or hypoproteinemia. Leishmania containing macrophages invade the bone marrow, the kidneys, and heart may also be infected. A few patients experienced a nodular macular rash known as post-Kala-Azar dermal leishmaniasis on the face, trunk, and limbs months to years after treatment. If untreated, visceral leishmaniasis is often fatal within 2 years. The standard therapy was pentavalent antimony compounds. However, lysosomal amphotericin B and paramamycin were used in the past few years. So this is the life cycle. So we have the organism being ingested by, or the amastigote is ingested by the sandfly, and then it transforms into the promastigote, and then the insect will bite and regurgitate the promastigote inside the body, and the promastigote is going to transform into an amastigote. And the amastigote multiply intracellularly, so inside of your cells. The diagnostic stage in humans is the amastigote, found in macrophages or histocytes around periphery of the skin lesions, found within cells of a bone marrow aspirate or liver or spleen biopsy specimen. Right staining of bone marrow aspirate reveals an oval pale blue cytoplasm with large red nucleus and a rod-like kinetoplast. The amastigote has also been reported extracellularly in cases of cutaneous leishmaniasis. Promastigotes have been identified in some patient specimens. Serological tests such as direct agglutination and indirect fluorescent assays can be used to detect antibodies in individuals from non-endemic areas. And there's the amastigotes of Leishmania species. Here's Leishmania donovani. And a few more pictures that you can review. Trypanosoma. So trypanosomes are blood and CSF flagellates that require an insect vector. Trypanosoma brucei and Trypanosoma brucei gambiense are the causative agents of human African trypanosomiasis, commonly called sleeping sickness or African sleeping sickness, seen primarily in Central Africa. The vector is the tsetse fly. So there's the West African sleeping sickness caused by Trypanosoma brucei gambiense, the East African sleeping sickness caused by Trypanosoma brucei rhodesiense, and Chagas disease or American trypanosomiasis caused by Trypanosoma cruzi. Trypanosoma cruzi is prevalent in the southern United States, Central and South America. African sleeping sickness. So the initial symptoms include a local inflammatory reaction with tenderness, edema, and erythema at the site of the insect bite. So this type of insect is capable of regurgitating this organism into the bite wound. It occurs within 2 to 3 days and lasts up to 4 weeks. During this time, the organisms are reproducing and beginning to enter the bloodstream. The first stage of the disease is the hemolymphatic phase, occurs 1 to 3 weeks after infection. Trypamastogotes enter the blood and lymphatics. The patient experiences generalized symptoms, enlargement of the lymph glands in the posterolateral triangle of the neck, edema in the legs and arms around the eyes is possible. The second stage, the meningoencephalitic stage, begins as the trypamastogotes invade the central nervous system. The patient develops severe headaches, mental dullness, and apathy, and may experience coordination problems, altered reflexes, and paralysis. Eventually, the patient has convulsions, lapses into a coma, and dies. So here's the tsetse fly. Tsetse fly biting of the human and ingesting trypamastogotes. They develop in the gut of the fly. The epimastogote goes to the salivary glands, and then it injected in by the human or into the human by a bite, and then those are going to spread and migrate potentially into the central nervous system, or they go through the blood, and then they can be transmitted from the blood when the next fly bites again. The diagnostic stage is the tryptomastogote, usually seen in a right stain blood smear. Wet films may be used to detect motile tryptomastogotes. Blood concentration methods are often needed because of the small number of organisms present. So there's a picture of Trypanosoma. Trypanosoma cruzi, causative agent of Chagas disease, is transmitted by the triatomid bug, also known as the kissing bug. Less common transmission routes would be blood transfusion, transplanted organs, congenital infection. Particularly hard on children, involve multiple organ systems. Adults have milder symptoms. In the acute phase, symptomatic or asymptomatic, after the insect bites, there's an incubation period that ranges from 2 to 4 weeks. As the organisms enter the blood, the acute phase begins and lasts 4 to 8 weeks. If symptomatic, local in nature, presence of a chagoma, ulcerative skin lesion at the site of the insect bite, or unilateral edema around the eye. Acute phase systemic manifestations include fever, lymphadenitis, hepatosplenomegaly, malaise, muscular pains, and diarrhea, vomiting. If untreated during the acute phase, the patient will most likely remain chronically infected. The latent phase develops as the trypamastogotes disappear from circulation and invade cells of the cardiac or GI system. Can last 10 to 40 years after infection, but only about 30 to 40% of patients develop the chronic form of Chagas disease, primarily cardiomyopathy. The chronic phase, chronic myocarditis, develops with damage to all heart chambers and the conduction system, may progress to tachycardia and eventually congestive heart failure. In some patients, chronic form may manifest itself as megacolon, megastomach, megaesophagus, which results in difficulty swallowing and disturbances in intestinal motility. Damage to the organs caused by a combination of continuous low-level parasitemia and immune-mediated tissue damage. Polyclonal B cell activation in the acute phase produces antibodies that have weak affinity for organisms and may cross-react with heart tissue. Controversy exists about the role of these autoantibodies in damage to tissue. When the patient enters the chronic stage of the disease, there are periods of intermittent parasitemia of trypamastogotes, during which time the organism may be transmitted. So here's T. cruzi. There's the type of insect. It's going to bite and inject those organisms, or it's ingesting, those organisms. They develop in the gut, turn into the epimastigote. They go to the intestine of the bug. Eventually, they're deposited in the feces near the bite. So when you scratch, or if the bug happens to trail some of that into the bite wound, they enter into the bloodstream through the bite wound. Tryptomastigote entry into the cells of the liver, heart, and macrophages, where they're going to then replicate and burst open, releasing more amastigotes. Then those transform back into trypomastigotes in the bloodstream, which can then be sucked up again by another triatomy insect. So Trypanosoma cruzi, just like T. brucei, typically detected in the blood. Xenodiagnosis is also possible. So xenodiagnosis, we actually have the bug bite a person, and then we examine the stool of the bug for several days after. If the bug happens to have those parasites, then we can assume that the person that it bit has the parasites inside of them. Rapid diagnostic tests using whole blood are under evaluation for testing individuals in remote areas. So here is T. cruzi, and you can see what that flagellate looks like. And here's T. brucei, so different structure. And if we want to compare the two, you can see the ends of them are different. So T. brucei, T. cruzi. So definitely take a look at these pictures and be able to differentiate them on the species level for the exam.